Thank you, everyone, for your patience. My name's Sarah Clark. This is session 2B, RAAM Innovations. I'm going to be moderating this session, and I'm just going to go over a couple of things before introducing our speakers. So everyone is in listen-only mode. If you have a question, please type it into the chat. I'll be keeping track of the questions, and at the end of each speaker's presentation, I'll deliver them to the speakers. If you need technical assistance, there should be a live assistance button, so you can use that to get some technical assistance. Polling questions will come up. They will pop up on your screen as multiple choice questions. And finally, at the end of the session, there will be a link to an evaluation form. So our first speaker for RAAM Innovations, so in this session, we'll be highlighting two innovative approaches to rapid access care for addictions. And our first speaker is Lindsay Reynolds. Lindsay is a registered psychotherapist who throughout her career has provided care to people who use drugs and alcohol. She's currently the opioid navigator at Lakeridge Health Hospital in Oshawa, where she works closely with emergency department patients to identify their unique needs and facilitate appropriate care in partnership with the healthcare team. She offers case management, harm reduction education, and advocacy for and transition to medical treatment, depending on an individual patient's needs. And she will be speaking to us about the opioid navigator role and the impact it has had on patient outcomes.
Thanks, Sarah. Sorry for the delay in starting. We had some technical difficulties. So I'm really thrilled to be speaking today at the Medify conference. I've provided treatment to people who use drugs and alcohol for the better part of 20 years in Canada and in the US. So everything I know about substance use disorder was graciously taught to me by our patients, so thank you to them. Like most of you, I've heard the stories our patients recount about their experiences in the emergency department. They speak about feelings of shame, feeling misconstrued, judged, harmed, and sometimes traumatized by the experience. My job is essentially to make recovery more palatable for our patients. So I was working in outpatient addictions at Lakeridge Health when I was first approached about a new role called the opioid navigator in the emergency department in Oshawa. I had no idea what a navigator was or how the role would intersect with the RAAM clinic. I had never worked in an acute care setting before, and I quickly discovered what the role would entail. I have no disclosures. Okay, so my learning objectives, obviously, what is a navigator? How does the role intersect with RAAM? And then I'll talk a little bit about some patient stories. Okay, we'll just skip through those. So why did Lakeridge Health identify a need for an opioid navigator? In Q1 of 2016, Lakeridge Health had 54 opioid-related visits. In comparison, Q1 2020, we've had 136 ED opioid visits. We're a very busy emergency department, and our visits are increasing exponentially year over year as this crisis evolves. So this is older data, but this graph depicts opioid poisoning by metropolitan area. Smaller cities across Canada are experiencing opioid overdose at an alarming rate, and Oshawa has been hit particularly hard by the crisis. Okay. So at our RAAM clinics at Lakeridge Health, they met with a lot of patients, but we believed we were missing out on a significant opportunity to treat a large portion of people who are using opioids in our community. We know that less than 15% of people with substance use concerns receive treatment. The emergency department can obviously be a challenging place to initiate treatment of substance use disorders. There's a number of traditional barriers. The ED typically treats acute illness as opposed to chronic. Treatment initiation takes a lot of time, and there are barriers, of course, due to stigma. By having an addictions ambassador embedded in the ED, we increase our chances of initiating the correct treatment, reducing revisit rates, and ultimately opioid-related mortality. Having a navigator in the department increases the sensitivity level of physicians in the ED to opioid use disorder. When we start people on treatment in the ED, we improve our outcomes. Having a navigator in the department allows us to identify opioid patients, obtain their preferences, negotiate a treatment plan, and initiate treatment all in one visit. As part of the opioid strategy at Lakeridge Health, hundreds of naloxone kits and fentanyl test kits have been distributed. Over 100 physicians have been trained to prescribe buprenorphine naloxone. The opioid navigator position was brought forward as an idea by the Durham Northeast Subcommittee of the LIN in 2018. Dr. Rahim Ladak, an emergency department physician, was a champion for the role, and Paul McGarry, the director of mental health, endorsed it. I was hired in January 2019, and I was pretty perplexed as to what a navigator would do. How many patients could there really be per day in the emergency department with opioid use disorder, or even in the hospital, or even in a large hospital system with 5 hospitals like Lakeridge Health? How would the role integrate with the RAAM clinics? And I quickly found out. So if we could flip to the next poll slide. So how many unique patients do you think the opioid navigator has connected with since starting treatment in 2019? Do you think 100, 500, 1,000? Everyone have their answers in? I'm not sure if the polling questions are working. Oh, okay. So 47 people voted. Let's see what they thought. Almost right. So the answer is more than 1,300. Okay. So we're just going to flip through. So the opioid navigator role was created to increase access to treatment for people who use drugs. The role was designed to reduce opioid-related visits, especially overdose visits, increase access to primary care physicians for our people, and to ultimately reduce opioid-related mortality. So what does an opioid navigator do? We're going to dive into this a little bit deeper. Okay. It's often difficult to identify a person who uses opiates in the emergency department. People who use drugs are often afraid to discuss their substance use. They present with infections, vague symptoms such as weakness or nausea, which we all know could be related to withdrawal. They sometimes present unconscious or unable to state their concern. The data in this graph shows the presenting concern for the opioid navigator patients in our department, and you can see that most people who present to the ED have concerns that aren't typically captured by opiate visit coding, and we needed to figure out a way to find these patients so we could engage them with our RAAM clinics. We use a combination of tools. We use our emergency department patient tracker, which states the presenting concern. We receive referrals from physicians, nurses, even pharmacy techs who interview patients about their medications and street drug use. Our fabulous clinical informatics team at Lakeridge Health created a system where we receive an email in real time when a person already involved with our addictions program presents to the emergency department. We needed to make our team sensitive to opioid use and teach them how to ask questions when the primary reason for the visit is not opiate use. Okay, just gonna flip the slide. So this is just an example of the email that we get in real time when one of our addictions patients presents to the emergency department, which has been a really handy tool to find people. Once the opioid navigator has identified a person who might require support, the patient is warmly greeted. We try to engage with the person, making them feel comfortable in the department. They may be thirsty, hungry, scared. We try to resolve the patient's basic human needs prior to their physician visit. We try to assess the preferences for the visit so we can liaise with the healthcare team to make a plan. You can see from the opioid navigator data that the number of visits or interactions per month are quite high for a one-person program. We've had 2,800 patient visits since June 2019. Luckily, we've received grants for homelessness supplies, including backpacks with food, warm clothing, sunscreen, comfort items. We've received sleeping bags, also donation gift cards, which we sometimes use as contingency management items for patients with longer length of stay in the hospital. More than half of the patients we see in the emergency department who use opioids are homeless or have unstable housing. %70 of them are not currently engaged in treatment. This creates high challenges for our emergency department staff with patient flow. Most people require community referrals such as RAAM clinic, shelter referrals, mental health supports. Having an on-site dedicated patient navigator helps to engage and retain patients in treatment so they have a better shot of meeting their goals. So the final step is to offer the patient a number of referrals during their visit based on their preferences. Consult with the healthcare team and make a plan. So prior to the pandemic, I would often accompany a patient to, a local pharmacy via taxi after their emergency department visit or the RAAM clinic. So after the treatment plan is made, the navigator role, it really has no limits. So if a person requires shelter, we help them in real time. We link them with obviously RAAM clinic supports, counseling, detox programs, mental health support, food, tents, sleeping bags, warm clothing, anything a person could require. Most of our patients don't have telephones, and this might be our only chance to do this type of work with them. If the patient is admitted to the hospital, the opioid navigator role includes working with the patient throughout their stay to improve their health outcome. While we don't have 24-hour coverage for the opioid navigator, we use data to create hours of operation. You can see our ED visits for opioid-related reasons typically occur in the evening, so the navigator works evenings. Tuesdays are our least busy day, so the navigator is off on Tuesdays. So here is a case, a quick patient story. So this was a young woman who came to the emergency department who'd been using heroin for 2 years. She was brought in by her mom and her brother, and she reported severe opioid withdrawal symptoms, and the opioid navigator advocated for her to start buprenorphine naloxone in the emergency department. The opioid navigator worked with the patient and family on a treatment plan. She was admitted to the psychiatry program at Lakeridge Health, and during her stay, she received daily visits from the opioid navigator, and who also acted as a go-between for the patient and her family. The patient during her visit disclosed she was a victim of human trafficking. So the navigator connected her with victim services. We work closely with victim services and started the assessment process while she was in hospital. There were multiple meetings with the psychiatry team, the social worker, victim services, the navigator, the patient, her family, to create a really solid plan. And the patient remained on our unit until she was admitted to a 3-month residential treatment program. And she was able to leave her traumatic situation and start a new life with her family. And this case kind of stands out to me because this young woman was so reluctant to receive treatment when she arrived with us. She was emotionally fragile, thin, physically fragile as well, and very reluctant to remain in the hospital. It took many skillful interactions with her throughout her stay in hospital to help her build hope and sell the idea that recovery was possible for her. She and her family were so thankful that she got the care that she needed and deserved. Okay. So we all know that the 5-year mortality rate for people who seek emergency department care following opioid poisoning is about 18%. This is why having an addictions ambassador in acute care setting can save lives. This is not my polling slide, so. Okay, this is my polling slide. So how does the opioid navigator role integrate with the RAAM clinic model of care? So she works to reduce stigma in the emergency department and hospital. She builds relationships with staff members who make referrals. She creates awareness of a RAAM clinic, or all of the above. All right, check the answers. Okay. Oh, you guys are so smart. So all of the above is the answer. All right. So patients who were engaged in treatment by a navigator in the emergency department start treatment at the RAAM clinic quicker. Starting treatment 8 days earlier could literally save a life when it comes to opioid use disorder. Since the navigator started working in the hospital, RAAM clinic referrals have increased by 11%. More referrals means more opportunity to start on treatment. At the start of the global pandemic, our program purchased cell phones for patients to be able to connect with our RAAM clinics, detox programs, and outpatient counseling, which has shifted to a telephone virtual model of care. The emergency department navigator was the perfect vessel to distribute these telephones to increase patients' access to treatment. So you can see there was a significant increase in patients obtaining cell phones. So opioid-related visits continue to climb, which we don't always view as a bad thing. We see it as an opportunity to help people change and start treatment. It's an opportunity to let people know about new treatment options available and try to increase the chances of building hope. So this graph shows the proportion of patients who attended RAAM following their emergency department visit. With opioid navigator interaction, the rate of attendance was 28% versus 13% with no interaction. When a person overdoses and ends up in the emergency department at Lakeridge Health, physicians use, can you go back to this other slide, please? Physicians use order sets to start treatment. The pathway always starts with a referral to the opioid navigator. This pathway form actually prints out with the order set to remind physicians that opioid patients have access to a navigator throughout their visit. This, I think, reduces fear in patients during their visit and provides them with the opportunity to start on treatment immediately. Okay, last patient story. So this was a 45-year-old male who had, no photo identification, no drug benefit coverage. He was homeless and he had been using heroin, crystal meth, cocaine, and cannabis for about 25 years. He came to the emergency department with a life-threatening infection and obviously developed severe opioid withdrawal during his stay on top of his medical illness. The opioid navigator advocated with the physician in the emergency department to start buprenorphine naloxone in the ED. The patient was actually admitted to the medicine program for about 3 weeks. And in that time, he received RAAM clinic addiction medicine consultations to optimize his medications. The opioid navigator arranged for a housing case manager who visited him in his hospital to start the process of obtaining housing. She helped him apply for ODSP and Ontario drug benefit coverage, as well as photo identification. The opioid navigator mediated calls between his probation officer and all of his physicians. And I think the thing I'm most proud of in this case is that he was reconnected with his mother. He hadn't seen his mother in about 15 years. And it just turned out that she had the same phone number as she did. And he was able to contact her and get reconnected. So at the end of his stay, the navigator, walked with him with his belongings to some crisis housing where he stayed for a few weeks and until he was able to connect with his more permanent housing. And so he is doing quite well now. So he has his own place. He's still using once in a while, but his health is improving. So the difference that the navigator brings in cases like these are, it's unlikely this person would have remained in the hospital for 3 weeks without the support of a navigator and the use of contingency management. This man's days in hospital were painful, frightening, and very boring. So having someone visit daily helps to infuse hope. The navigator offered resources to increase this person's chances of survival. He had no family, friends, home, no income, no identification, and he was left permanently disabled by his injuries. But he was happy to be alive, and he left the hospital with a new start. Okay. So part of the navigator role entails working to reduce stigma in the hospital environment. The navigator provides formal and informal training to staff members, including best practices for care, treatment availability and programs, and information on how stigma prevents people from seeking recovery. The navigator completes chart audits to provide feedback to healthcare providers. Changing emergency department culture, though, it's not about metrics. The navigator has developed real relationships with physicians, nurses, pharmacists, people throughout the hospital. They hear my language, they see my patient interactions, they read my clinical notes, and I think that makes a difference in care. I think the most impactful part of the navigator program is that the navigator knows the personal stories of patients in the department. She can provide nurses and physicians with background information on these patients to help them develop empathy. I know the names of their mothers. I even know their pets. And I think that this helps humanize our patients to healthcare providers. Addiction patients often have no family members to advocate for their care, and the navigator can help fill this gap. So Lakeridge Health recently hired an addiction medicine physician, a fabulous, smart woman named Dr. Sajida Afridi. And we have developed an addiction medicine consultation team that we offer to all of our patients at 5 hospital sites at Lakeridge Health in the Durham region. So here are my learning objectives again. And I thought that we could just review these. It might spark some questions, or if there was anything that I left out, maybe you might have some feedback or other things that you had wanted to mention. I quickly wanted to thank Dr. Larry Nijma and Dr. Joanne Gorgavelis for helping me with my presentation today. So if you have any questions, might be a good time to ask them.
We have got some questions in the chat, which I will ask you. The first question was about the follow through of the people in terms of connecting with services for which you've provided a referral. Do you have any information about that?
Yeah, so we keep data on that, but a lot of the data is anecdotal, so I tend to follow up with people by telephone and just connect with them and make sure that the referral was successful, or if it didn't work, maybe we need to try something else. And I see a comment about using the word homeless person can be stigmatizing, so thank you for that. I'll make a change in my presentation.
Another question that came in was about your hours and days working in the ED and what you do if you don't have a patient in the ED or an inpatient that you're looking after.
What's interesting is that there's always a patient to see in our hospital. So I don't think there's been a day where I haven't been very, very busy. We're constantly getting referrals, more than what we can actually manage.
A technical question about your employment. So is the opioid navigator a hospital employee or RAAM employee? Or
so I work for the Mental Health and Pinewood Center program at Lakeridge Health, which is separate from RAAM. But I work in the emergency department, which is a bit confusing, but I'm not actually I'm a hospital employee, but not actually connected with RAAM, but I attend all their meetings.
We probably just have time for, we have time for a couple more questions. So the next one is, are you able to speak to some successes in building relationships or building comfort in prescribing various addiction medications in the emergency department?
Luckily, we have a team at Lakeridge Health who has created a strategy. So there were a few champions, Dr. Larry Nijma, and Dr. Joanne Gorgavelis, who were part of the opioid strategy initially, who trained many physicians throughout our hospital, oncologists, pediatric specialists, our infectious disease physicians, psychiatry, and the emergency department doctors who did a fellowship in RAAM, meaning they observed the RAAM team for a few days. They attended trainings, and it wasn't me that developed the comfort level with prescribing. Obviously, I'm a registered psychotherapist, not a physician or medical person.
Great. Another question is, how did you find a champion within the hospital system to support the navigator position? The comment being all hospitals should have a navigator integrated into their system this way.
I agree. So Dr. Rahim Ladak is an emergency department physician at Lakeridge Health who treats many, many people prior to me starting for opiate use disorder. And I think he noted that this role would be useful, and he sits on the Durham Northeast subcommittee, and I think he had just built relationships there and started the role with the help of Paul McGarry, the mental health director, Chris Jones, the emergency department director. Just had so many visits, and I think Dr. Mel earlier had talked about just the grief, healthcare grief, watching people suffer with opioid use disorder, particularly in Oshawa, and we knew we needed to do something.
Great. And I think one final question, what percentage of people get housing, access to withdrawal management, and so on?
For that, it's a little bit tricky because, I mean, access to withdrawal management, if I make a referral, I'm not sure the exact numbers, to be honest. Like, our system is very, very taxed. We don't have enough beds at residential withdrawal management. We just don't have the resources to link everyone. There are wait times, but I think if I can bridge the gap with those wait times with counseling, telephone calls, visits, that sort of thing, and other outpatient referrals, it can help.
Great. Well, thank you very much, Lindsay. That was wonderful. And we're getting comments in the chat about an amazing role, beautiful and articulate presentation. Thank you very much, Lindsay.
Thanks so much.
Great. So our next speaker, the speaker for the second half of the session, is Jennifer Eyford, who is a registered nurse who's based in Calgary, Alberta. Her work has had a strong focus on harm reduction for people who use drugs and on building health equity for marginalized populations. Jen is the Associate Director for Mental Health and Addictions at the Alex Community Health Centre in Calgary, and she brings advocacy for client-centered and trauma-informed care to this role. And Jen will be telling us about the Alex RAAM Clinic. Jen, welcome. Thank you very much.
Thank you so much. Can everybody hear me? We had a few technical issues earlier, and I have to apologize to the team. That was totally on me here in Alberta, Calgary. So maybe that's the reason why I'm so far away, that we had some issues at the beginning. So that was not on Lindsay. So thank you so much for being tolerant of this new way of doing conferences. So I just want to really thank you all that you have made time in your day and space in your mind to have a conversation about what we're doing here in Calgary, Alberta at the Alex with the RAAM model. We think it's quite innovative, but we're also eager to learn from you. I think of conferences in a two-way street, and I'm offering information just as much as I'm hoping to learn from all of you guys and understand what you're doing. I would like to let you know that the Alex RAAM Clinic is funded by Alberta Health Services and Health Canada. This program has not received in-kind support, and there's no potential for conflict of interest. Sadly, I don't have any relationships with financial sponsors, and I don't have any relationships that may pose a potential conflict of interest. With that out of the way, let's talk about some more interesting topics. What I hope you take away from today is a description of what we have tried, and I'm really looking forward to engage you in a discussion about the challenges to innovation as well. The Alex is a mid-sized community health center with about 350 staff, and we consider ourselves nimble and even gritty, and we innovate not for the sake of innovation, but in the spirit of improving client care and health outcomes. We always ask the question, how can we make our work more client-centered? And we are so committed to this that even our mission statement includes the word innovative. The Alex started as a small community health center, and we have always challenged ourselves to respond in new ways to needs in our community. And most people in Calgary will associate the Alex with our health buses that you can see here, which are actually fully functioning doctor offices on wheels. They provide medical care at homeless shelters, schools, and addiction treatment centers, among other service providers. And often folks are really surprised to find out that we have many, many other programs, such as our Housing First programs. Our Housing First programs are probably the area of our work that I feel most emotionally connected to, and where I started as a green baby nurse some years ago, and where I always say I grew up clinically. These programs provide housing and medical care to about 400 formerly homeless individuals. And the reason why I share this with you is that this was the first program to join the 10-year plan to end homelessness in Calgary. Another innovation is our Community Food Center. Community Food Centers Canada, and I believe the headquarters is actually in Toronto, asked the Alex to open the first community food center in Western Canada. We serve thousands of meals per year, and we created a bright and welcoming space where people can grow food, cook food, share food, and also advocate for food. Flexibility and being responsive is truly in our DNA. So when we heard about the RAAM model, we truly embraced it. There's actually a really neat connection between Toronto and our RAAM clinic. Everything started when Dr. Hassan Sheikh, and I think he is in the audience, so thank you very much, Dr. Sheikh, from the RAAM clinic at Toronto Western Hospital, joined the Calgary Mayor's office as part of the Bloomberg Harvard City Leadership Initiative, and he did a comprehensive review of our addiction services in Calgary last summer. One big gap that he identified was a lack of RAAM services. Dr. Sheikh ended up touring our organization and connected with our CEO, Joy, who you saw on my first slide. Joy was really excited about the RAAM model, and the rest is truly history. We opened our doors earlier this year, and I'm happy to report that our first patient recently graduated. He had come in on his birthday in February and wanted to give himself a gift, a sentiment that actually really touched me, and I'm happy to report that he's doing really well and was discharged back to his primary care provider. We're also really excited about some really early stats. We currently have 66 patients, 44% female, 56% male. 44% have an alcohol use disorder, 35% an opioid use disorder, and 33% a stimulant use disorder. And I understand that that's actually quite representative for other RAAM clinics as well, where the alcohol use disorder outweighs the opioid use disorder. Our team consists of 2 addiction counselors, a nurse, a medical office assistant, a peer support worker that we are in the process of hiring, a lead and a medical lead, and a really good mix of addiction medicine specialists, primary care providers, and nurse practitioners. There were several barriers to overcome, such as securing funding, translating the model into an Alberta context, and figuring out how to fit this model into a community health center framework. We engaged community members with lived experience because we really wanted our clinic to be trauma-informed, warm, and really welcoming. we had a sign made that read, "We are so happy you're here," and we wanted that energy to come through in all places. We also brought together a steering committee consisting of community partners and stakeholders to anticipate obstacles and to troubleshoot them right from the beginning. And one of these obstacles that our steering committee identified was medication coverage, which was our first innovation. Many of our clients don't have medication coverage right away, and it takes 24 to 48 hours to get emergency funding through the province approved. And often clients can wait that long. And we are very lucky that we have a pharmacy that we work with, and we included medication coverage in our funding proposal so that clients can see a provider and walk out with medications at the same time. This seems to really improve client engagement and also treatment retention, and prevents less advantaged Calgarians from missing out on the care when they are ready for it. Mental health supports, our second innovation. And I know I'm preaching to the converted here, but we all know that mental health concerns and addictions go hand in hand, and often addiction issues can't be addressed if the underlying mental health issue is not. Significant mental health challenges are best dealt with by a specialist, often by a psychiatrist, and the current wait time to get connected to a mental health clinic in Calgary is multiple months. We arranged a really new service approach to overcome this obstacle, and we talked to our health center psychiatrist to provide our RAAM patients access to psychiatry. Our patients are not paneled with a psychiatrist, but they're being seen on a consultation basis for diagnostic clarity, treatment recommendation, and a follow-up visit. At that time, the RAAM provider can take over, and the psychiatrist's caseload does not increase. We're still a really young program and really new to this game, but we always like to keep our eye on things that could be up for us on the horizon, and also to really adapt to the needs that our community has and to be able to respond to them. So one idea that was inspired by our housing programs, which delivers healthcare in an outreach capacity, was to provide addiction medicine that way. Bringing a service to a community member's doorstep is removing several barriers like transportation and potentially even stigma. And we heard from Lindsay that stigma truly kills. We are currently working on finding the right vehicle, considering operational challenges such as staffing, safety, all of that in the context of COVID, obviously, and always, always, always sustainable funding. Lastly, we're in the process of joining forces with other community service providers here in Calgary who also offer rapid access services such as counseling, low-income supports, suicide bereavement, and family care by utilizing an online platform where people in need can directly book an appointment, usually within a day. We're in conversation with this group and consider offering additional intake appointments in addition to our walk-in spots this way, and then provide a phone intake instead of requiring clients to come in, which once again removes another barrier. Let's see whether this is working. In what areas do you see opportunity for innovation in your clinical settings? Maybe I inspired you, maybe there is something that you're already doing that I would love to hear about in the chat box. Interesting. Oh, there we go. Okay, I see non-traditional professionals. Interesting. I mean, I just kind of threw out the therapy doc, but I think there's so much potential, whether it's a dietitian or some other clinical professionals that could really enrich the RAAM experience. And on the flip side, what obstacles to innovation do you see in your clinical settings? Lack of leadership support, funding as always, policy procedural constraints, and unfortunately, sometimes also often community supports or lack thereof plays a role. Kind of, okay. Yeah, I feel you, lack of funding as always. And sometimes it feels like we all want to collaborate, but we are all kind of having our eyes on the same pot of money. And sometimes I feel some collaboration is lost that way, that there is just not enough money to go around for all these good ideas and all these services that we want to provide. And finally, which of the discussed innovations could be or even have been incorporated in your clinical settings? Maybe you have an even better idea than providing access to psychiatry or having the first few days of medications covered. I'm really interested in it. I think that's where the learning really happens, and we can benefit from one another's expertise. Okay, I see access has been on people's mind. That's wonderful. I think we all know, in especially primary care, it's all about access and being able to provide a service when the client is ready for it, not when the service is ready for it. So yeah, fabulous. Thank you. Thank you very much. And I'm wondering whether there are any questions. And if there are no questions, please share your innovative approaches to RAAM. What have you tried that we could try here in Alberta, or maybe you can inspire programs in your neighborhoods? I'm really curious. It doesn't have to be a question. It can be a comment or something that you have tried that you would like to share with the group.
Jen, thank you so much. Really great to hear about how this model has been adapted for the Western context. So that's wonderful to hear. A few questions have come in on the chat line. One of the questions is about, do you have any tips on how to get primary care providers to take their patients back post-RAAM?
Fabulous question, and I certainly can't say that we haven't run into that ourselves and have problem solved around this. So increasing capacity has been very much on our mind, and we've been trying to do that in different ways. So one thing we do is at the beginning of us accepting patient care, we send a courtesy letter to the primary care provider, really explaining what our treatment course is, so they get a little bit of a better understanding. We invite them to contact us and ask any kind of questions. And then when we send a discharge letter, when it's time for graduation, we really invite them to consult with us, or even throughout the patient's journey, to really benefit from the expertise from our providers, who are obviously quite comfortable. We have also tried to be more creative in terms of offering trainings. We have engaged clinics in our immediate neighborhood, but yeah, I would be lying if it's not challenging at times to engage the broader primary care community, just because I think there's a little bit of nervousness that is not always warranted. Maybe a little bit of stigma is something that I'm venturing, and I think it will just be an ongoing responsibility and a little bit maybe of an uphill battle to engage primary care and really let them know addiction medicine should be sitting in primary care, and it can be done.
Yes, indeed, and I think this particular challenge is one that we have talked about throughout since we've been doing Medify is getting that primary care buy-in and connecting. And there have been some comments in the chat about people not having primary care providers and the challenges there. Another question has been, are medications dispensed right out of the RAAM at the time of the visit?
Yes, so we have a pharmacy in-house that we partner with, and if they need, they're free to use the pharmacy. If they have coverage, there's no expectation or any kind of mention made. If they don't have coverage and we're covering the first few days, they will receive that medication right after the visit if they want to. They just show up at the pharmacy counter. Our pharmacists are incredible in terms of trauma-informed care, patient education. They actually are a very integral part of our work because they do our flu shots, our hepatitis B shots. They do a lot of the Suboxone education. They are very valuable team members. So, and yes, the client walks in and is able to receive medication very early days. When we had same day provider appointments, they would come in for an intake, they would see the provider maybe an hour later, and they would walk away with their medication all within like 2 hours. And people said this is absolutely unheard of. And we kind of manage expectations because obviously that is a pace that we won't be able to keep up moving forward. But we very much are committed to stay within the best practice guidelines for RAAM, 3 to 4 days, absolute maximum. And actually right now we're still under those 3 to 4 days. So within just a few days, clients can have a real treatment plan. And I think what's really important to point out here is the concept of hope. I think people walking in not knowing what to expect and where this journey could take them, they trust us enough to walk through the doors, and then they get that glimmer that things could really be different for them, and they get the diagnosis. They know this is a legitimate disease of the brain and not something that they should just try harder to battle. And this journey has been really magical, and I know that sounds so corny, but I'm so grateful that Dr. Sheikh came all the way out west and brought this model to Alberta. I'm truly grateful.
Yes, Dr. Sheikh was one of our participants in our early project, so we know how influential he is and how dedicated. Another question, a couple of other questions. If you have RAAM clients who are not rostered to your clinic as patients and they see your psychiatrist, do you bounce them back to the family physician to monitor new meds that may have been prescribed?
So our RAAM patients have access to consultation services with psychiatry, and then the RAAM provider is taking on the prescribing. If there's like an antidepressant that the psychiatrist is adding or whatever it may be, the RAAM provider continues that on. And I also want to say that our RAAM providers have grown incredibly comfortable with dealing with psychiatric medications as well. But if they want diagnostic clarity, they're pulling the psychiatrist in, and then the RAAM provider would take over the prescribing of whatever the psychiatrist has recommended.
Great. A question. What does the Alex Clinic offer with regards to contingency management in treating your folks with stimulant use disorder, if at all?
Oh, I so love this question because we have been actually this week just talking about this probably on a daily basis. We have really come to understand, and I think we're just kind of late to the party, that is the one thing that we need to get really, really good at because we have so few other things in our toolkit. And there are actually meetings booked in the coming weeks to come up with a very solid framework to provide contingency management in different settings. So I think right now with COVID, it's a little bit harder to do the group setting for contingency management. That is something that I'd always dreamt about, and I think we kind of need to step away from that or be really creative how that could still work for us. We are in the process of building a framework how to offer robust contingency management in a one-on-one setting. And we also, just like the medication coverage, work that into our funding proposal. And because the funding proposal got approved, we have financial ways to really do do a robust contingency management program. But we're just in the early stages. But I think in the last couple of weeks, something has shifted. We have been talking as a team, and we're like, let's go to town. We need to get a hustle on that. This is really important for our clients. You saw 33% of our clients have stimulant use disorder, and we just know that from the data. So
there are a few more questions in the chat, but I'm seeing that the evaluation survey has popped up, and I see a timer counting down from 2 minutes. So I think we might be booted off in a couple of minutes. So in case we get cut off, I just wanted to thank Jen and Lindsay both for their wonderful presentations about the very important work that they do. And thank you all also for participating in this session. So I'll continue with a few more of these questions while we have time. Where do you see the biggest failures of current RAAM models?
Is that a question for me? The biggest failure? Wow, that's a toughie. I'm still kind of in the rainbow and ponies phase. That is a tough question. I think in order to keep your doors open, which is the true magical thing about RAAM, that people can walk in, you need a very robust discharge pathway as well. And sometimes I'm wondering whether we just need larger RAAM clinics with more providers, so we can perhaps go beyond the early recovery but stay with the clients. They're trusting us so much in the beginning, and to just be able to not make it a short-term program or even intermediate program. But what we understand about addiction is that the long-term support, the lifelong support, likely is what keeps people safe and alive. So being able to have maybe a closely connected second stage RAAM model. We have had some conversations as a team about that. We have been kind of tongue-in-cheek calling it SAM, Stable Addiction Medicine Program, and we have not really developed that further because we're just early days. But people need to be able to stay connected well beyond their early recovery. And obviously right now we are solving that by working on transitions to other long-term services. But I think there's a potential for a gap between the early recovery support and then the ongoing services. And all RAAM clinics obviously operate in a climate of that other services are not necessarily as nimble on their long wait list. So it can be really tricky, and that might be. I'm shying away from the term failing. I don't think that's a failing, but that will be perhaps an ongoing challenge for us, that we operate in an imperfect world. So not that we're perfect, but we operate in a challenging addiction medicine landscape.
Yeah, that's a really good point. And we didn't get booted off, so if folks don't mind sticking around, there are still some more questions in the chat. One of the questions was about tips for quick intake and assessment.
Whoa, I'm like the new kid on the block, and I get asked all these really intelligent questions. Thank you for that. So I'm still doing some intakes. Thank God we have a wonderful nurse now who is just in the process of taking that over. Quick intakes, man. We modified our EMR in a way that we use templates that keeps the interviewer and like the nurse really focused and makes sure that we ask all the things that we truly want to ask in the first visit. But I think also an attitude of not everything has to be asked and answered the first session. The first intake should just truly focus on how much information do we need in intake, and how much information that the provider need to be able to confirm the nursing diagnosis and then prescribe medication. Do we need to really dive deep into psychosocial history, all these things? Perhaps not, because we also all know from the data that the first RAAM visit is often the last of a person. Do we really want to? Is it even ethical to be sitting on all this information if we may not ever see this person again? So I'm not sure whether that's a tip, but really critically ask yourself how much. The team already has heard me say this many times, but as much as necessary and as little as possible. So get what you need, but all the extras, the first meeting, you can get to it the second, third, and fourth meeting. I'm not sure whether that's helpful, but that's how we have kind of approached this.
Great. Okay, so we're going to wrap it up there. Once again, Jen, thank you so much for that presentation, and Lindsay, thank you as well. And thank you to all of our participants in this session. Just a reminder that there will be, at the end of the day, there will be some networking sessions. So if Jen and Lindsay are able to participate in those, you might get a chance to chat a little bit more about these innovative programs happening at Lakeridge and at the Alex. So thank you all very much, and I hope you enjoy the rest of the day.
Thank you so much.